Aku Arif, awak style ni. Tapi tak kena.
Recording in progress.
Assalamualaikum.
Waalaikumsalam, Dr.
So how many of you are going to present today?
Four of us, Dr.
Okay, maybe you can start now.
You guys can see my screen or not?
Yes, we can.
Okay, we start now. Assalamualaikum warahmatullahi wabarakatuh. My name is Wafi Aiman bin Udin. So today we will start with muscular dystrophy. So the table of content for my presentation. First, I will describe about muscular dystrophy, the overview, the definition, types, classification, and etiology. And then we move to the most common types of muscular dystrophy, which is the Duchenne muscular dystrophy, regarding definition, epidemiology, pathogenesis, clinical presentation, differential diagnosis, investigation, complication, and also management. So the first one is regarding muscular dystrophy. So the definition is it is the group of genetic muscle disease at which we have progressive myofiber degeneration and also gradual replacement of muscle by fibrotic tissue. As we can see from the picture below, the normal muscle of the bicep, and then we can compare with the atrophic muscle. So this is the muscular dystrophy presentation. Regarding the type, we have a few of them, and then the one listed here is Duchenne and Becker types, Emery-Dreifuss type, limb-girdle type, facioscapulohumeral type, oculopharyngeal type. So this is this picture show the main areas of muscle weakness in different types of dystrophy. But today we will only look to the most common one only. So we move to the classification. We have three kind of classification. The first one is X-linked recessive. The second one is autosomal dominant, and the third one is autosomal recessive. So for X-linked, we have Duchenne, DMD, Becker muscular dystrophy, BMD, and also we have Emery-Dreifuss muscular dystrophy. For autosomal dominant, we have facioscapulohumeral, myotonic, oculopharyngeal, distal, limb-girdle, and also Emery-Dreifuss. For autosomal recessive, we also have limb-girdle and Emery-Dreifuss, but we will only focus on DMD only. And then because of DMD is X-linked recessive, so it is most commonly seen in male infants. And some resources say that this DMD, Duchenne muscular dystrophy, is exclusively for male. The next one is etiology. Muscular dystrophy is caused by mutations or alterations in the genes responsible for healthy muscle structure and function. So it leads to the muscle weakness and progressive disability. So I already explained about types of muscular dystrophy. We have many of them, but all of them is not due to same pathogenesis. For example, we have dystrophinopathy. It is the pathogenesis in the Duchenne muscular dystrophy or Becker muscular dystrophy. And then we have calpainopathy, and other is dysferlinopathy, which is not as common as Duchenne muscular dystrophy. So this is the difference between Duchenne muscular dystrophy and Becker muscular dystrophy, because both are caused by dystrophinopathy, but and there is some difference between them. I will go through it later. So we move first to the Duchenne muscular dystrophy epidemiology. It is the most common hereditary neuromuscular disease, and then the most common muscular dystrophy. It is quite common because it is its ratio is 1 in 3,500 in male infants. Etiology, it is X-linked recessive disorder, and it can also occur de novo due to de novo mutation in 1/3 of the cases. It is due to deletion of some parts of the chromosome that encode for dystrophin protein. So this dystrophin protein is a function to stabilize the muscle cell wall. We will look what is the dystrophin protein later. So here is the function of dystrophin. It connects the cytoskeleton of a muscle fiber to the surrounding extracellular matrix through the cell membrane. So we have three components here. Extracellular matrix is connected to the F-actin, which is the cytoskeleton muscle fiber, by the dystrophin protein. So the pathogenesis of Duchenne muscular dystrophy is, the first one, there will be a gene mutation of the respective gene that result in inability of the dystrophin protein to be produced, and then the body will lose of dystrophin, and then the myofibril membrane will become unstable, and then there will be influx of extracellular calcium into the muscle fibers, And then the creatine phosphokinase (CPK) will be released from the muscle and then will be markedly elevated in the blood. And then the next is there will be muscle death due to the excess calcium ion influx into the muscles. The muscle undergo proteolysis and then will be replaced by the fibrotic tissue and also fat. So all of this is the simple explanation regarding the pathogenesis of the muscular dystrophy. Here is the more complete one regarding the pathogenesis and how the pathogenesis lead to the clinical finding that we find in the on the patient. But I will not go through this because it is almost the same from the what I explained before. So this is the clinical manifestations of MD, muscular dystrophy. It is rarely symptomatic in early infancy. We can also see there is poor head control during infancy, mild slowness in attaining motor milestone, or in simple way is the patient is a late walker. And then the clinical onset, it is onset between 2 to 3 years of age. And there will be also delayed motor development, cognitive and intellectual impairment, slower and clumsier than their peers, progressive muscle weakness, and also delayed speech and language. So we can see from the picture, this is how the patient of muscular dystrophy appeared. The shoulder and arms are held back awkwardly when walking, and then we can see the hip straightened. The hip will be straightened to the backs because of weak back muscles, and then the knee will also bend, and then we can see the two walking appearance of the patient. The tight heel cord, child may walk to. It is called two walking. So this is the list of clinical manifestations. The first one we can see Gover signs, which is a difficulty in getting up from sitting position due to proximal muscle weakness. The child cannot stand without the help of their hand. And then the second one is Welling gait, duck-like walk, wide base gait due to the weakness in the gluteus maximus and gluteus medius. And then the third one is lumbar lordosis, which is due to the hip extensor weakness. And then we have two walking. And then others is like pseudo hypertrophy of calf, like the second picture on the above. And then we have cardiomyopathy. The specific type of cardiomyopathy is dilated cardiomyopathy. And then we have a respiratory decline because respiratory muscle will also affected. And then we have scoliosis and then macroglossia. The concept of macroglossia and pseudohypertrophy is almost the same, at which the muscle at that component of the body will be death and then will be replaced by fibrotic and fat tissue. That's why it appears big in size. And then we move to diagnosis and investigation. When to suspect patient with muscular dystrophy. So first we do take the history taking, and then we ask the patient does they have a family history of DMD. And then if there is, we look for evidence of delayed motor milestone in a young child. So if there is evidence of delayed motor milestone, so we can do further investigation to detect for DMD. But if the patient has no history of DMD, we look if the patient cannot walk by 16 to 18 months or presence of Gover sign. Gover signs to walking or calf hypertrophy. So for the investigation, we have 4 of them, but the first one is the most important, which is the markedly elevated creatine kinase and also muscle biopsy. And then for CK levels, we can see it is 10 to 100 times greater than normal range. And then genetic testing for dystrophin gene mutation, muscle biopsy, as we can see from the picture, there is absence of dystrophin staining. And then we can do also electromyography. So if it is not DMD, we can look for other differential diagnosis that can be present. That can be present in the patient other than DMD. For example, Becker muscle dystrophy, limb-girdle muscular dystrophy, Emery-Dreifuss dilated cardiomyopathy, and spinal muscular atrophy. So for the complications, the patient might have heart failure because of decreased heart function due to dilated cardiomyopathy. And then the patient can also have respiratory failure because of weak diaphragm. And then the patient might also requires a wheelchair because of loss of muscle mass, inflammation of the muscle, and then fibrosis. So the remaporide here is the experimental drug, the experiment of drug to treat this muscular dystrophy. The management, the goal is to manage the symptom, complication, and improve the quality of life because muscular dystrophy cannot be treated fully. So the first one, we can give steroid therapy to slow down disease progression. And then we can do molecular genetic therapy to increase the production of dystrophin. And then we can do supportive care. For example, like proper wheelchair, treatment of cardiopulmonary dysfunction and pulmonary infection. And also we can give counseling for the patient. So I think that is all regarding the muscular dystrophy. If you guys have any question regarding the muscular dystrophy, you can ask. We proceed to the next presenter.
What is the hypertrophy of the cuff?
Pseudo hypertrophy.
Sorry, can you ask again?
Why patient with DMD has pseudo hypertrophy of the cuff?
Because at the cuff we also have a muscle. So in muscular dystrophy, the cuff muscle will be cuff muscle, and then that muscle will be replaced by fat and fibrotic tissue. That's why the cuff appear big in size, but it is not muscle mass. It is a fat and fibrotic tissue.
May I know why it is just the cuff? Is it because of gravity?
Sorry.
Why it is specifically in the cuff, or is it because of gravity?
I'm not sure about that. I think I will look for it and then I reach you later. Other question? So we proceed to the next presenter. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Hana Abra binti Khalid, matric number 2012688. So my topic for today's seminar is acute glomerulonephritis. So this is my presentation outline. I'll start with the definition of AGN, followed by epidemiology, etiology, pathophysiology, clinical features, complications, investigation, differential diagnosis, and lastly, management of AGN. So definition, AGN can be defined as a specific site of renal disease which immunological mechanism triggers inflammation and proliferation of glomerular tissue. So it is characterized by an abrupt onset of one or more features of acute nephritic syndrome, which includes edema, hematuria, oliguria, hypertension, and exothymia, which means elevation of blood urea nitrogen and serum creatinine levels. So epidemiology, AGN predominantly affect male with 2:1 male to female ratio. Worldwide, the predominant cause is IgA nephropathy. In Malaysia, the commonest AGN in peds is post-streptococcal glomerulonephritis. So it is common in children aged 6 to 10 years old, usually develop after 1 to 2 weeks of streptococcal infection, either the skin or throat infection. No predilection for any racial or ethnic group. A higher incidence may be observed in some socio-economic groups, which may be related to poor hygiene. So etiology can be divided into infectious and non-infectious. Infectious causes, the most common cause is bacteria Streptococcus, specifically strain of group A, beta hemolytic streptococci. So patients that had pharyngitis or skin infections such as impetigo might later develop EGN. Other less common cause is viral infections such as herpes virus like Epstein-Barr virus, hepatitis C, parasitic infections such as malaria and schistosomiasis. And non-infectious causes could be primary renal disease such as IgA nephropathy and membranoproliferative glomerulonephritis, or autoimmune diseases such as systemic lupus erythematosus, Hinox-Sconlin purpura, or Good-Pasteur syndrome. And then pathophysiology, firstly, antigen. For example, strain of group A beta hemolytic streptococcus will initiate a type 3 hypersensitivity reaction where immune complexes composed of antigen and antibodies are formed. So these complexes will be carried by bloodstream to the glomerulus and become trapped. So these complexes will end up being deposited in the glomerular basement membrane. So they will initiate inflammatory reaction, which involve activation and deposition of citric complement and also inflammatory cytokine. So this will all damage the podocyte at the glomerular basement membrane and results in hematuria and proteinuria, but proteinuria is relatively mild in AGN. On the other hand, the deposition of immune complexes at the GBM increase the glomerular cellularity. So this will restrict blood flow and decrease the GFR, resulting in reduced urine output and cause fluid retention. So the patient can present with edema, oliguria, exothymia, and hypertension. So clinical features, on history taking, the patient might present with specific symptoms of AGN, which is facial puffiness, edema, either periorbital, pedal, and scrotal edema, smoky or tea-colored urine, which indicates hematuria, and reduced urine output. Patient may also present with non-specific symptoms such as anorexia and lethargy, and also abdominal pain. Further examination may reveal cardinal features of AGN, which is edema, hematuria, either microscopic or macroscopic, with or without proteinuria, exothymia, which is elevation of blood urea, nitrogen, and serum creatinine, and oliguria, which is decrease in urine output, and hypertension. And general signs include papillary edema and skin lesions such as impetigo or cellulitis. So complications of AGN, renal system, AGN can progress to nephrotic syndrome, rapidly progressive glomerulonephritis, and irreversible renal failure. Respiratory system can cause pulmonary edema due to the retention of the excessive fluid in the lungs. CNS complication is hypertensive encephalopathy. Early presentation, patient might be restless, drowsy, and headache. Late presentation is visual disturbance, vomiting, nausea, seizure, or coma. So blood system can cause severe uremia and hyperkalemia, in which patient can present with cosmos breathing, which is deep and rapid breathing pattern due to the metabolic acidosis, and cardiac arrest due to the cardiac arrhythmia. So investigation, urine analysis and culture, there will be hematuria, in which red blood cell is distorted and fragmented due to the hemolysis, complete hemolysis. And proteinuria usually trace up to 2+. Red blood cell count is pathognomonic for AGN. Pyuria, white blood cell in urine, may be present, and bacteriological and serological evidence of preceding streptococcal infection may reveal raised anti-streptolysin O titer more than 200 international unit per milliliter, and then increased anti-DNase B is a better serological marker for preceding streptococcal skin infection, and throat swab or skin swab. And renal function tests reveal elevation in blood urea and serum creatinine. There might be electrolyte imbalance, and full blood count might show leukocytosis. Complement level, C3 will be low at onset of symptoms and normalized by 6 weeks, but C4 usually within normal range. And renal ultrasound can be done to evaluate the kidney size, echogenicity of renal cortex, and to determine the extent of the fibrosis. Renal biopsy is not necessary if patient has clear-cut acute nephritis syndrome based on the history and physical examination. So for the indication of renal biopsy is steroid-resistant atypical presentation or severe acute renal failure, prior history of renal disease or family history of nephritis, and there is features suggesting post-infectious AGN as the cause of acute nephritis and delay resolution, in which oliguria is already more than 2 weeks, azotemia is more than 3 weeks, gross hematuria more than 3 weeks, and persistent hematuria more than 6 months. So next is differential diagnosis. First one is membranoproliferative glomerulonephritis. So for positive findings, it is a nephritic syndrome. So patient might have the features of acute nephritic syndrome that I've mentioned before, and elevated ASO titer and hypocomplementemia. But the negative findings, hypocomplementemia occurs more than 6 to 8 weeks and markedly reduced renal function. IgA nephropathy, positive findings, hematuria, and associated with respiratory illness. But negative findings, it is a recurrent illness and uncommon hypertension and edema. ASO also not elevated, increased serum IgA and normal serum complement. Hinox condyn purpura, positive findings, hematuria, mild proteinuria, preceded by URTI in 50% of cases. But negative finding, there is characteristic skin rash and associated with abdominal pain, arthritis, arthralgia, and normal serum complement. So next differential diagnosis is familial nephritis or Alport syndrome. So positive finding, it is a nephritic syndrome, occurs 1 to 2 days following URTI. Negative finding, there is lack of expected complete resolution and associated with non-renal manifestations such as hearing and ocular deficit. And lastly, lupus nephritis, positive findings, hematuria, mild proteinuria, and hypocomplementemia. Negative findings, there is lack of expected complete resolution and associated with non-renal manifestations such as skin rash. And in lupus nephritis, C4 also reduced and there is detection of anti-nuclear antibodies. So next slide is the outline of management. So firstly, strict monitoring on fluid intake, urine output, daily weight and blood pressure, and then antibiotics, penicillin V for 10 days may be given to eliminate the beta hemolytic streptococcal infection, and give erythromycin if the penicillin is contraindicated. Fluid restriction to control pulmonary edema and circulatory overload during oliguric phase until the child diuresis and the blood pressure is controlled. And diuretics is indicated in pulmonary edema and hypertension. Diet is advised to be salt-free, but protein restriction is unnecessary. And then we must look out for hypertension and complication of AGN such as hypertensive encephalopathy, pulmonary edema, and acute renal failure. And lastly, dialysis. So the indication for dialysis is acute pulmonary edema, hyperkalemia, severe acidosis, and uremic symptoms. So these are my references, and that will be all for my presentation. If there is no question, I pass to the next presenter.
ODP ya?
Continue our presentation with nephrotic syndrome. So my name is Nafah binti Muhammad Faris. So nephrotic syndrome. Okay, so this is my outline for the nephrotic syndrome. I will explain regarding the definition, epidemiology, etiology, the pathogenesis, the history taking for nephrotic syndrome patient, the physical examination, and the investigation to rule out any diffusion diagnosis for nephrotic syndrome, the management, complication, prognosis, and also diffusion diagnosis. So, by definition, nephrotic syndrome is a clinical syndrome which is defined by edema, hypoalbuminemia, proteinuria, and also hypercholesteremia. So, if you see here, I listed out the criteria for the nephrotic syndrome, which need to be, the criteria that need to be that need to reach this level so that it can be categorized under nephrotic syndrome. Then we go for epidemiology. So nephrotic syndrome can occur at any age, and it is more prevalent in children. So the case can be like 16 case of children in 100,000 case in 100,000 population of children. So for children, it usually occurs in between age of one and a half a year and also 4 years age. And then for the male and female, the ratio will be 2:1. So next for the etiology, we will categorize the nephrotic syndrome into two, primary and also secondary. So for primary also means idiopathic. So the commonest type of nephrotic syndrome will be idiopathic in children, but in idiopathic, so the commonest will be the minimal change nephrotic syndrome. So the minimal change here means that the finding will be that the, in minimal change, you will see like an diffuse effacement of the food process of the podocyte. So podocyte is one of the element for the glomerular.
Sorry, presenter.
Yes.
Can you increase the volume? I think we can barely hear your voice.
Okay, Kak.
Still slow, Farha.
Mungkin Pak A boleh dekat sikit mic.
Yeah, okay.
Okay, maybe you can use the device, the mic on your device.
So buat dua orang. Okay. Kalau tak guna ni dengar ke?
Dengar better.
Jelas lagi lah daripada guna ni. So do I need to repeat that from the start or I can just continue?
You can continue.
Continue. So Okay, I think I stop here. So for the etiology for nephrotic syndrome, we can divide it into two. First is primary, or we also call it idiopathic, and second is the secondary. So for primary, we look for so usually primary is the most commonest type of nephrotic syndrome in children. So one of the type for idiopathic, which is the most commonest one, is minimal change nephrotic syndrome. So for minimal change nephrotic syndrome, so what we can see here is that there will be a diffuse increasement of the food process of the podocyte. So what is podocyte? So podocyte is one of the three element that is needed for the glomerular filtration barrier. So in minimal change nephrotic syndrome, there is problem at the podocyte. So here, the 80% case of the minimal change nephrotic syndrome is around below 7 years old. So next type is the primary focal glomerular sclerosis. So this type of nephrotic syndrome is that when there is a segment in the glomeruli, there is sclerosis, but it happens without any inflammation. So here you can see an increase in mesangial matrix for this type of nephrotic syndrome. And next is membranoproliferative glomerular nephritis. So this is also one of the differential diagnosis, if I'm not mistaken, in AGN just now. So for this type of nephrotic syndrome, it it is mostly the key point here is that there is a immune complex deposit at the meningeal region and also at the capillary wall. Okay, so that is membranoproliferative nephritis, and then we go to membranous nephropathy. So membranous nephropathy means that the antibody, our own antibody, attack the podocyte. So here, one of the characteristics is you will see a generalized thickening of capillary basement membrane. Okay, and then last one for the primary type of nephrotic syndrome is congenital, which occur usually at the first 2 months of life. For the secondary means that the patient will have underlying other disease that can lead to a nephrotic syndrome. So first is autoimmune disease. So one of the common autoimmune disease that can lead to nephrotic syndrome is Hennard Schönlein purpura and also SLE. And the next one, the patient may have underlying diabetes, amyloidosis, chronic infection, allergens, CHF, which is congestive heart failure, renal vein thrombosis, and also malignancy. Okay, next we go to the pathogenesis. So here I want you to focus at the top one because that is the main pathogenesis for nephrotic syndrome. So nephrotic syndrome, the key point here is that there will be a damage to the glomerular filtration barrier. So if you look at the top here, I don't know if you guys can see my cursor. Okay, so if you look here, for those who have the type of membranous glomerular nephritis and also minimal change disease, just now I mentioned, so these two types lead to the antibody to attack the podocyte and also thickening to the glomerular basement membrane. So here podocyte and glomerular basement membrane is one of the two elements in the glomerular filtration barrier. So with this damage, it will also damage the podocyte. So here will be destroy the charge barrier to the protein filtration. So once the protein is, so this will lead to protein is more accessible to be filtered out into the urine. Okay, so next you will have the type of focus at metaglomerular sclerosis. So here is regarding the immune complex. So once the immune complex is deposited into the glomerulus, it will also injure the barrier. So it also lead to the same presentation, which the protein will be massively filtered out. Okay, so under here is just the presentation that I mentioned, which the clinical syndrome, which is hypoalbuminemia, proteinuria, and also hyperlipidemia. We go to next. So here is a picture regarding the element in the glomerular filtration barrier. So first you will need to have the endothelium fenestrated endothelium. Second is glomerular basement membrane, and here is the podocyte food process. Okay, so any injury to this element of the glomerular filtration barrier, it leads to injury and also massive filtered out of protein in the urine. Okay, for history taking. Okay, so mostly the most common presentation for nephrotic syndrome will be edema or swelling. The patient will say that they will have swelling at the face or at the limbs. So mostly the site for the edema or swelling will be at the periorbital, scrotal, sacral, and also pedal. So the onset will be insidious. So the patient will characterize the edema or the swelling will be soft, non-pitting or non-erythematous, and the swelling will be generalized. And usually the guardian will notice that the child will have this swelling during the morning on their face and also at the leg when the patient is standing. So the associated symptom that can come in with the patient is fatigue, loss of appetite, abdominal pain, and also decreased urine output, and also foamy urine. Foamy urine because of the protein itself, proteinuria. So next we look for the past medical history. So we need to ask our patient if the patient have any preceding infection or have any underlying diabetes, heart disease, malignancy, or even SLE, which is one of the autoimmune just now. So for medication, we ask if the patient is on NSAID or penicillin. So why we need to ask here is because these two medication is common for the drug that can induce acute interstitial nephritis. So acute interstitial nephritis means that this drug or this medication can reduce the kidney function itself, which can lead to inflammatory mediators will infiltrate into the kidney interstitial. Okay. So for the family history, we ask if the family, the parents or any siblings have any renal disease or autoimmune disease. And for the nutrition, we ask for the patient regarding the protein intake and also any allergy. For physical examination, commonly we will see swelling at the skin, and if the patient have underlying SLE, autoimmune disease, so we will see rash. So for at the eye, we will focus on the periorbital edema, and for respiratory, we look for any sign of pleural effusion and also pulmonary edema. So why? Because once the patient, so usually patient with nephrotic syndrome, the condition is that they will have low oncotic pressure. So low oncotic pressure means that not a lot of fluid will be filtered inside the vessels. So this fluid will be accumulated. So it will go to maybe it can go to the pleura and also the pulmonary, so lead to this pleural effusion and also pulmonary edema. So that's why you look for this any sign. And then cardiovascular, we look for any third heart sound. So why? Because just now for any for the underlying for the secondary nephrotic syndrome, if you remember, we have congestive heart failure. So if we can hear this third heart sound, so maybe the type of nephrotic syndrome will be secondary. So it will not be idiopathic. So this is just to rule out the type of nephrotic syndrome. For abdominal, we will see it will be distended, tenderness, and we also look for the test shifting downwards and also fluid. Okay, so next for the investigation, I focus on these 4 investigation. First is the blood, so we look for the FBC. We look for the any evidence of infection and also hemoconcentration. So ESR for any inflammation, views, and also creatinine. LFT, liver function test for for the evidence of hypoalbuminemia. Okay, and then for the serum complement level, why complement level? Because with in the urine, there will be a lot of loss of complement and also protein. So here we look for the serum complement level. So usually they will be reduced in C3 and also C4. So this also can lead to this is also can be one of the evidence for AGN also. Okay, so then next is serum anti-streptolysin O titer and also anti-DNASB. So this is one of the investigation to rule out the post-streptococcal glomerulonephritis. So this, so if we can rule out that, so this can be confirmed with nephrotic syndrome, and also with blood we can screen for hepatitis B. And then after that we look for the urine. So urine dipstick for proteinuria. So if that result come in with 2+ or 3+ and above, so it can lead to evidence of persistent proteinuria. So then we look for 24-hour urine collection, and usually it is done in older children. So the one here which is UFEME, so this stands for urine full examination, microscopic examination. So this together with culture and also sensitivity. So for this type of investigation, usually we done to look for the how much loss of protein in the urine. So like the nephrotic range of the proteinuria itself. Okay, so how much the protein loss in a day. Okay, and then for urinary sodium concentration, we look for the indication of hypovolemia with low sodium. And then for renal biopsy, so renal biopsy usually not indicated for idiopathic syndrome. Means that if the nephrotic syndrome is idiopathic and good response to steroid therapy, we don't usually done renal biopsy. But if it is otherwise, the patient have steroid resistance, steroid therapy resistance, so we done it for this type of nephrotic syndrome. And then we have imaging. Okay. Continue with management. So here I take from the pediatric control. For nephrotic syndrome, first we initially start with prednisolone corticosteroid here. So if and we look for the response. If it has good response, so usually it will lead also with good prognosis. But if there is no response towards the steroid therapy, so we done with renal biopsy. Okay, and then we also have specific management if the patient have relapse of nephrotic syndrome or any frequent relapse, and also relapse while on prednisolone itself, and also given with oral cyclophosphamide. When I try to find about cyclophosphamide, it say that it usually indicate to lower the body natural immunity. So if that nephrotic syndrome is because of the immune system attack our glomeruli, so usually we give oral cyclophosphamide, and then also relapse for the post cyclophosphamide. So this is a specific management in nephrotic syndrome. Okay. So I continue with the complications. So here I type down 3 most common complications for patient with nephrotic syndrome. Okay. So okay. So first we have hypovolemia. So how can patient have hypovolemia? Because hypoalbuminemia, one of the syndrome for nephrotic, will reduce the plasma oncotic pressure. So now the patient will have loss of fluid into the interstitium. So for hypovolemia, the patient may come in with abdominal pain, cold peripheries, poor pulse volume, hypotension, and also hemoconcentration. So for the next complication is primary peritonitis. So because it is due to urinary loss of immunoglobulin and also complement. So with this, the patient are susceptible for infection. So the features will be fever, abdominal pain, and tenderness. So these features can come with either those who are newly diagnosed and also relapsed nephrotic syndrome. For thrombosis, so it is a hypercoagulable state. So means that the patient will have a lot of loss of coagulation factors, antithrombin, and also plasminogen. Okay, for the prognosis, so approximately 80% to 90% of children with proteinuria resolve with steroid and also do not progress to renal failure. So the key point here for the nephrotic syndrome is that once the patient have a good response to steroid therapy, so it will lead to good prognosis. So so here we can divide the prognosis if respond good with steroid or not respond good with steroid. So if respond good towards the steroid therapy, you have here one of the type is minimal change nephrotic syndrome. So it is one of the type of nephrotic syndrome that is good response towards steroid therapy. But about 50% of the cases undergo relapse within 5 years, and approximately 3% who respond well with steroid therapy can also lead to steroid resistance. But for those who do not respond well with steroid therapy, and one of the example of that type of nephrotic syndrome is focal segmental glomerular sclerosis. So approximately of that patient, approximately 20% of that patient will have remission of proteinuria. So they also will have frequent relapse, steroid dependent, and also steroid resistant. So I emphasize again that for nephrotic syndrome, the prognosis is once the patient have good response to the steroid therapy, so usually the prognosis will be good. Okay, and then we go to differential diagnosis. So differential diagnosis here, I focusedly look on for the patient or the children that come in with edematous sign. So like edema, swelling. So for the differential diagnosis that we need to rule out first is does it from allergic reaction, or does it from congenital heart disease or chronic liver disease, or maybe from protein losing enteropathy or malnutrition itself. Okay, so what is meant by protein losing enteropathy? So it is means by when there is a protein or the albumin, or maybe substance that are rich in protein, they leak out into your intestine. So like condition like when you have an infection or any tumor like that. So if the substance that rich with protein leak out, so it can lead the patient to have protein losing ability. Okay, so that's all from me. This is the reference. So if do not have any question, I continue with the next presenter. Thank you.
Alright, so Assalamualaikum warahmatullahi wabarakatuh. My name is Murshida Matmirzuki with metric number 2013540. For the last topic for today would be SLE, systemic lupus erythematosus. These are the contents for my presentation. Alright, overview for SLE. Basically, SLE is a chronic autoimmune disease. It causes widespread inflammation and tissue damage at the affected organ, which involve multi-organ like joints, skin, brain, lung, kidney, and etc. And for the epidemiology, around 15 to 20% cases of SLE occur before the age of 18 years old, and the onset mainly occur during puberty age, 10 to 12 years old. And it is predominantly affect the female rather than male. So the causes of SLE is unknown. However, some studies believe that it is linked to some factors, including environmental factors. For example, UV exposure, because it increases the cell apoptosis, and it is also a well-known trigger for SLE. Other causes like drug, for example, antiarrhythmic like procainamide or hydralazine, which is vasodilator, it got highest incidence for drug-induced lupus. And it also can be due to infection like Epstein-Barr virus. Other factor is genetic factor, which lead gene mutation affecting the complement protein, mainly C1q and C4, and it can be associated with HLE. And the last factor will be hormonal factor, for example, estrogen and prolactin, because some said that these two can promote autoimmunity, and even some cases of SLE got high prolactin level. However, it is not well understood. So for the pathogenesis of SLE, so interaction between those factors just now, it somehow elicit the production of autoantibody and autoreactive T cell. So this autoantibody will bind to the self-antigen and it will form the abnormal immune complex. So when there is immune complex, there will be activated of complement protein, and then there will be a release of abnormal cytokine. So this cytokine, this complement protein, it will attack the healthy cell, which subsequently causing the organ damage. That's why it leads to the manifestation of SLE. So here are some clinical features of SLE. As we know, it is widespread. So it can affect many systems. Therefore, patient may come with any of these symptoms. But the one that I want to highlight is the malar rash and discord rash, because 60% of SLE patients presented with malar rash and 10% of SLE patients came with discord rash. So what are the different? We can see in the picture. So this one is malar rash, commonly called as butterfly rash, because we can see the pattern of rash is like involving both cheek and nasal bridge. It's like a butterfly shape. And for the discord rash, it's more like circular in pattern. But again, not all SLE patients will come with the rash. So it depends on the person itself. Next, we go through the investigation and expected finding. So we can do the routine blood test like FBC, ESR, CRP, or if we want to see whether it affects the system, we can see the renal profile, liver function test, or urinal lysis. And more specific investigation like anti-nuclear antibody or extractable nuclear antigen. So ANA function to detect the presence of autoantibody in the blood. Meanwhile, for the ENA, we want to know what kind of antibody is there. So in 95% of active untreated SLE, there will be positive ENA. However, it is not diagnostic without clinical feature. So the patient must have clinical feature together with positive NNA. Only then we can suspect them with SLE. And another one, the more specific one, like anti-double-stranded DNA antibody and also anti-Smith, 30% got this anti-Smith, which is one of the most specific antibody for SLE. And for ENA, anti-Ro and anti-LA mostly associated with neonatal lupus. However, bear in mind that anti-Ro and anti-LA, it can also be presented in Sjogren's syndrome, which is another kind of autoimmune disease. So other tests like complement level, coagulation profile, thrombophilia screen to see whether there is antiphospholipid antibody which predispose to blood clotting, or other investigation like skin biopsy, renal biopsy, or imaging. So now we go to the differential diagnosis. I classify into 3: autoimmune, infection, and malignancy. So for autoimmune, it can be the juvenile idiopathic arthritis. So JIA mainly is like rheumatoid arthritis in adults, but this one is more in children. So mainly the patient will come with joint pain, joint stiffness, joint swelling, but again, because it is autoimmune, so they may come with any symptom. And another one is Sjogren's syndrome. In children, mainly come with unexplainable rash and fatigue or lethargy, but Sjogren's syndrome in adult mainly come with dry eye or dry mouth. Other differential diagnoses like infection, Epstein-Barr virus or cytomegalovirus, and for the malignancy, leukemia or lymphoma. All right, for the management, aim of management in SLE, first to reduce and control the disease activity because we want to prevent the organ failure. And then we want to maintain the function of the organ, also help the patient to cope with the disease, also the treatment. Because this disease is a chronic one, so it requires a long-term treatment. And the third one, to minimize the side effect of treatment. So we can classify treatment into general and specific. For general, it's mainly to protect from the sun or sun protection. Because UV exposure or sunlight, it can trigger the SLE. So it can cause flare-up, which is worsening of symptom in SLE. So the patient, we may advise to wear sunblock or maybe reduce the activity under sunny day. And also the second one, treat the symptom. So let's say the patient got fever, we give PCM. Or let's say they got arthritis, give NSAID, or maybe the infection, give antibiotic. And the other treatment is specific treatment. So corticosteroid is a mainstay therapy for SLE. And we can also add other drugs like immunosuppressive agent or hydroxychloroquine, which help to reduce flare and reduce autoantibody production. Or we can also give rituximab. This one only for the resistant cases of SLE. So for the complication of SLE, first is infection. Because we know the disease itself, it causes the patient in the state of immunocompromised. Also due to treatment like steroids, so it causes immunosuppressive agent. So the patient is more likely vulnerable to the infection. Second is renal failure or any organ failure. Because we know SLE, there is ongoing organ damage. So over the time, the organ may become damaged, more damaged, and lead to organ failure. Also can be a pulmonary hemorrhage or neurological disease, but this one is more like rare complication. Okay, so these are the reference, and I believe that's all from my part. Thank you.
So any question from audience to all 4 presenters? Maybe I give a bit, not a comment lah, mungkin maybe an input. Okay, first for Duchenne muscular dystrophy, actually is under a big topic, actually under one big umbrella that we call lower motor neuron lesion, or patient with muscle weakness. So inducible muscular dystrophy is at the end of the lower motor neuron lesion. So if patient came in with, most of the patient will come to us with progressive muscle weakness or muscle weakness only. So in your mind, you need to have a few differential diagnosis. If you see in the lower motor neuron lesion, it started at the anterior horn cell, and then it go to peripheral nerve, and then it go to your neuromuscular junction, and then your muscle. So each of these lesion at this particular site have their own disease. So Duchenne muscular dystrophy or muscular dystrophy is at the end of the muscle. So your finding, you will have a lower motor neuron lesion. Sometimes patient will have hypotonia, hyporeflexia, as well as muscle weakness. And for Duchenne muscular dystrophy, the question that your friend asked regarding why pseudohypertrophy occur in the lower limb. Actually, the pseudohypertrophy is not only occur in the lower limb, specifically in the calf area, but it also involve the thigh and the pelvic area. But I think because compared to thigh and pelvis, compared to your calf muscle, the thigh and pelvis have a large group of muscle. So if it is replaced with the fibrosis or store, actually you cannot see compared to calf muscle. So calf muscle, there's a group of muscle there, and if it's displaced with the fibrosis and the fat, it's become more prominent. So that's why we see it's more common occur in the in the lower limb, but it also occur in the thigh and the pelvis. I think because it's replaced with the group of muscle is less compared to the thigh and pelvis. So that's why you see that calf is more prominent. And the other etiology, I think, is remain unknown. But the principle is there. So Duchenne muscular dystrophy, the clinical presentation is straightforward. A patient may have a proximal muscle weakness. So how you do it? Like your friend say, from the clinical examination, you look for the muscle wasting, pseudo calf hypertrophy, and then see patient walking. So from walking, we also can diagnose the patient. And the most specific one is the waddling gait and Gower sign. So patient need to climb up from sitting position to a standing position. So we suspect patient have Duchenne muscular dystrophy. From the investigation, because of there is fibrosis, muscle death, so CK will be high. But some there is other differential diagnosis came in with CK high. For example, post-viral myositis. So some of the patient we have increase in the CK if patient have post-viral myositis. But the difference is the clinical presentation. The patient do not have a muscle weakness. So you can, after you have CK, you do your EMG, do a myobiopsy, sometimes you do a gene mutation, and then we treat the patient accordingly. But most of them, this one is a progressive muscle weakness. So that's why patient may some of them may last for about 20 or 30s of age. If they have good respiratory support, they may live longer than that. Because most of the time we have a respiratory failure. Once you have respiratory failure, you're prone to get infection, you're prone to get aspiration pneumonia, and then you're prone to have apnea. So most of them we have problem with that. And then on top of that, because of the muscle weakness, it also affected the heart. So you have a dilated cardiomyopathy. So that's why they cannot last longer. Regarding the medication, What the medication? Lupa dah.
The
the
steroid, Doctor.
The trial medication that you mentioned earlier, that you mentioned experimental.
Rimipride, Doctor.
Yes, rimipride. So basically the rimipride, yes, as you mentioned, is still experimenting medication lah. But they already started to give to the patient. So their aim is to stop the influx. As you mentioned, the pathophysiology of Duchenne muscular dystrophy, because of there is imbalance between influx of the calcium and sodium into the extracellular, right? Intracellular. For calcium from the extracellular go to the intracellular. So this medication try to inhibit that, to prevent the imbalance between the intracellular calcium and sodium. So but in Malaysia, I don't know whether we have that or not lah. Maybe in HKL, because cost for this drug is very high. I think that's for Duchenne muscular dystrophy. Regarding the nephrotic and nephritic syndrome, both of them came with edema, but there is a difference in terms of pathophysiology behind the edema. So for example, in nephritic syndrome, we know that because nephritic syndrome, AGN, acute glomerular nephritis, or the most common we call post-strep AGN lah, post-streptococcal infection AGN, because it's the most common cause of the AGN. Usually because of the activation of your immune complex. Once you have antigen in your body, our bodies try to react, forming the immune complex. So you affected the glomerular membrane and reduce the GFR. So that's why in nephritic syndrome, the edema is not because of the albumin. The edema is because of the reduced GFR. So once GFR reduced, the renal will send the message that your renal is low in perfusion. So you activate what? What system involved?
RAS system.
Yes, RAS system. So your renin-angiotensin,
Aldosterone.
yes, aldosterone system. So that's why it's tally with the clinical presentation. So edema because of your water, right? So your angiotensin and aldosterone will act on the various part of your body lah, including in the aldosterone, it can in the tubular, it can cause water retention, and then it also act in the vessel. It increase the sympathetic activity, cause vasoconstriction. So that's why you have hypertension. So in the tubular, it can cause the absorption of the sodium as well as water retention. And in the adrenal cortex, it can cause aldosterone secretion. It also involved in the water retention. And then in your pituitary gland, ADH, also involved in the water reabsorption. So that's why in the nephritic syndrome, you have edema, you have hypertension, you have oliguria, azotemia. If the symptom is very bad, you can have azotemia, and you can lead to hypertension and encephalopathy. So that's why in nephritic syndrome we give furosemide to reduce the water. Compare we give another drug lah, like CCB, calcium channel blocker. So for nephrotic, the edema is because of the low oncotic pressure. So low oncotic pressure cause albumin in the intravascular low, so reduce in oncotic pressure. So water inside the intravascular will go to the extravascular into your cell. So there is an accumulation of the water in your third space, right? So that's why patient have edema, and because of the low albumin, the body say that there is a low albumin, so it will activate your lipogenesis, hepatic lipogenesis. for example, LDL, total cholesterol, your lipoprotein. So that's why it can cause hypercholesterolemia. So it depends. The management is dependent. Even say that patient have edema, it doesn't mean that patient have a lot of water. But some of them patient edema, but they divided into hypervolemia or hypovolemia. So it depends on the volume in the intravascular. It's not depends on the volume in the extravascular. So if patient have hypervolemia nephrotic syndrome, patient have tachycardia, palpitation, BP high, you can give albumin because increase in the volume in the intravascular. If patient have hypovolemia, you can give furosemide. That one you give furosemide. If hypovolemia, cold periphery, clammy, anasarca, prolonged CRT, you give the albumin to increase the to maintain the oncotic pressure. So once you give steroid for management of nephrotic, we try to reduce the loss of protein in the urine. Once you able to control the loss of protein, the albumin will increase and patient will cause less edema. And actually the nephrotic syndrome, nephrotic and nephritic is depend. Nephrotic is more for me is more challenging because the management is long. You have to give induction for 28 days, followed by maintenance 28 days, and then you need to taper within 48 days. If steroid sensitive. So most of them will have relapse. So you have to know what is relapse, what is steroid dependent, steroid sensitive. And then that one you can see in the your PICS protocol. And then the last one for SLE, actually basically you forgot to mention about the SLEEK criteria. You did mention all the clinical criteria, but usually we diagnose patient SLE based on the SLEEK criteria. So what is SLEEK criteria? SLEEK criteria is a combination of the criteria lah. You need to have one is clinical criteria and one is immunologic criteria. So if you have more than 4 criteria, at least one clinical and one immunologic criteria or lab criteria, you can diagnose a SLE. So in your clinical criteria, you have cutaneous, lupus, odor, nasal ulcer, alopecia, arthritis, psoriasis, renal, neurologic, anemia, leukopenia, thrombocytopenia. And immunologic criteria, you have ANA, anti-double-stranded DNA, anti-Smith, anti-phospholipid, low complement, direct test. So if you have this criteria, at least more than 4, so you can diagnose the SLE. And then the management, as your friend mentioned, our aim is to reduce the inflammatory process and antibody reactions. So we give all the steroid, we give all the immunosuppressant. And then most of them, if complicated, we will refer to hospital Selayang, especially under rheumato, if patient complicated with lupus nephritis or lupus sebritis. Okay. Any question?
I have a question for Sister Farha about the nephrotic syndrome. Why, if the patient is not responding to steroid, why do we need to do renal biopsy, and what do we expect in patient who does not respond to steroid?
So presenter, why?
For what I understand, when I read regarding steroid therapy response, is that when there is no response towards steroid, it said that maybe it can lead to more chronic disease, more chronic kidney disease. So that's why they do renal biopsy. I don't know, doctor. Not sure.
And then why do we need to do the renal biopsy? And what do we expect? Is there any differences between those who respond or not in the renal biopsy? My question is, why do we need to do the renal biopsy in patients who do not respond to steroid?
So, what I understand, we do renal biopsy because mostly we want to know the management for our patient. So if that patient do not respond to steroid therapy, so then we do renal biopsy to look for any other, we look for other differential diagnosis for our patient. So that's why we manage according to result from the renal biopsy.
For example,
I'm sorry, I don't know. Maybe I can try to search more and get back to you.
Okay. Actually, for steroid resistant, why we need to do a renal biopsy? I think in terms of you want to have because not all we do a renal biopsy. So the steroid resistant, after you start a 28 days of steroid, so patient not responsive, mean that urine protein still 3+, 4+, and patient still have clinical edema. So usually in this type, actually clinician already know that it's not a minimal change disease. So most of the minimal change disease, that's why in steroid responsive, we actually all patient need a steroid biopsy to confirm the histopathology, but we spare it in patient with steroid resistant. Because we want to document, actually it's mainly because of we want to document that this patient have FSGS. If patient have minimal change disease, for example, maybe it's not because of steroid, it's not respond. Maybe it's because of the compliance to medication is not good, how patient take the medication, so that's why it's not respond. But when we do a renal biopsy, we want to know what is the histopathology of the renal. Most of the time is non-minimal change disease. For example, FSGS. Usually the poor prognosis is FSGS. So when we know that it's FSGS, we have to try other medication. For example, cyclosporamide, cyclosporine, or combination of both two, or we need to other immunosuppression like azathioprine. Depends on the histopathology. If we know there is a minimal change disease, maybe we can try a steroid. Maybe we give another 2 weeks and see how. Sometimes the clinician is not very rigid regarding 28 days. Most of the nephrologists may allow up to 6 weeks of the induction, but they want need to consult the nephrologist. So if 28 days not respond, okay, we suggest for renal biopsy to look what is the histopathological to confirm our diagnosis, because we cannot simply start patient cyclophosphamide. We need to have the evidence. We can start, okay, patient refuse. Unless patient refuse, we can. But most of the time, we need to have evidence to say that this is not a minimal change disease. This is other than that. It's non-MCD minimal change disease subtype, which is not respond to the steroid, but may respond to immunosuppressive therapy, like I mentioned earlier, cyclophosphamide, cyclosporine, or combination of azathioprine. So some of them may have about 20 to 30% of them may have respond with the immunosuppressive agent. So yes, I think that's all. Am I answering your question?
Yes, thank you, doctor.
Okay. Is there any question? Any more question? So if not, maybe we can end our session. Hello. Hello. Any more question? No more. Hello.
I think no question, Doctor.
Okay. So if no more question, maybe we can stop. We can end our session.
Okay, so I think we can end our session with tasbih kifarah and surah as.
Subhanakallah bihamdik, syahadu an la ilaha illa anta, astaghfiruka. So thank you. Good. See you all again. Thank you.
Thank you to Doctor.
Thank you, Doctor.
Thank you, Doctor.
Yeah, thank you.